The topics and opinions expressed in the following show are solely those of the hosts and their guests and not those of W4CY Radio, its employees, or affiliates. We make no recommendations or endorsements for radio show programs, services, or products mentioned on air or on our web. No liability, explicit or implied, shall be extended to W4CY Radio or its employees or affiliates. Any questions or comments should be directed to those show hosts. Thank you for choosing W4CY Radio.
Welcome to the Ask the Expert show on W4CY Radio and Talk4 TV, where we bring you educational information from top local experts in the fields of legal, health, financial, and home improvement. Now sit back and listen to experts in family law, association law, hearing loss, business brokers, home care, along with many other topics. Now here are your hosts, Steve-O and Sophia.
Hey, good afternoon, Houston. Welcome to another Ask the Expert show where we bring you the top experts in the field of legal, health, financial, and home improvement. Listen, you got a great show when, we promote our show on iHeart and YouTube and Facebook so people know what show is coming on Ask the Experts. And we're getting a little bit of a late start today, and I've already counted 8 people have called already from the Houston, actually one's from San Antonio area about today's show. Let me welcome you. Today's going to be an incredible show. We've actually never done a show like this before, and leave it to Dr. Ludwig to come up with an incredible show. Let me introduce you to Dr. Ludwig with Sugarland ENT and Sleep. Good afternoon. Now, is the hat because it's so cold there?
Yeah,
or did you just get out of surgery?
We had snowmen in our front yard. It's freezing here.
I know it's really cold there, and we're here in Florida. It's even cold for us. 50 degrees.
Yeah, we had like 4 or 5 inches of snow, believe it or not. It's like
that's amazing.
Lifetime thing. So.
Our great producer Rebel is in southern Louisiana, and she told me it's snowing there. It was snowing there too, but hey, welcome. I cannot wait to get started. You've got a whole presentation today.
Well, I was trying to come up with a way to, that's interesting for people to learn about sleep apnea and how we take care of it. And so I thought maybe if we just did some real life patients I take care of, I think that you'll find very interesting how these patients chose the treatments they chose, and I have some before after photos, and I think it'll be very interesting for everyone listening and hopefully watching. There's only so much you can describe verbally, so I thought this would be a very good kind of show and tell style.
Tell people about your practice, James.
See how it goes. I'm a solo practitioner. I trained at Baylor in the Med Center, and I've been in solo practice since 2006, and we treat sleep apnea, sinus, allergy, nose type problems. I dispense CPAP equipment for the last 20 years. We dispense oral appliances, do sleep surgery, just try to take care of all the issues related to sleep apnea and or nasal breathing. That is a cofactor in treating sleep apnea a lot of times.
Let's get at it. Let's start.
All right. Well, what I want to do, if I got to wait a second because I'm like locked into this download thing. Why don't we just chat for a minute until this download's done? Sorry that we're experts in sleep and not in video presentations.
And your practice is in Sugarland, but you have patients from all over, not just Houston, but all over the surrounding areas too.
Yeah, I have patients come see me from Dallas and San Antonio, Houston, the Southwest towards Corpus Christi. There really isn't a lot of ENTs southwest of us. Of course, there's some presence in Corpus Christi, but it's very minimal once you get past Sugarland. So, we draw from a large area there. I think we're good. Let's see here. Let me try this. Slides. Okay. Let's see if this works. Help me. I picked it. Where'd it go? Can y'all see it? No?
No? Not yet.
Go down to your present button.
Mm-hmm.
Click on the present button. Allow it Let me,
I can see what I want right here. I double click it, my screen changed to a full screen.
that's what you see, but you need to share it with me. The bottom where it says present, go to share screen.
It says your browser's blocked your screen.
We actually know it works because we just tested it just a minute ago.
Yeah. There it goes.
Ah,
Interesting. Delayed. Okay.
yes.
So yeah, so we hopefully the people who are listening can see this picture, but if just in case you can't, I'll try to give a verbal. But basically, this is a what we call a sagittal view of the upper airway, and there's the nose, and then there's the mouth. You can see the tongue. You can appreciate how big your tongue actually is. If you didn't appreciate, I always tell people, if you've ever been to a meat market, you see a cow tongue, you realize how big tongues can be. We only see a very small portion of our tongue. And then behind the tongue sits the epiglottis, which is that cartilage that folds over our voice box when we swallow so we don't aspirate. It's kind of the same kind of cartilage that your ear has, same fibroelastic cartilage. And then the trachea there, and then the esophagus behind it. So sleep apnea is a problem with the space behind the tongue and near the palate. And this is the area that we're trying to figure out what's going on when patients want other treatments outside of air pressure. So when patients come to see me, one of the evaluations we're going to do in the office, we're always going to look at that area with a camera. We have a flexible, it's only a 3mm camera. And this is a rendering of an actual patient photo. This is the artist rendition. I use graphic software called Rendia that I actually helped them like 15, 20 years ago with these images. When they first met me, they just had those kind of like the ones you see at doctor's office on a laminated sheet, just the static photos. And then we actually made these endoscopic animations. We also have all sorts of animations for ENT problems. And so this is the airway looking down from the back of the nose, looking down towards the voice box. So this is the part of the airway that's obstructing when someone suffers from having a sleep apnea event. And this airway is what I like to call an ideal airway. It doesn't mean that someone who has this exam can't have sleep apnea, but clearly someone who has this exam has a lot of room in their airway. And this is awake, and you can see, maybe appreciate the uvula there kind of hanging down. Again, this is a view that you're not used to seeing, but this is looking down from the nose towards the voice box. You can see that white letter V, those are the vocal cords. And then that little pink tissue sticking up from the cords is the epiglottis. And in front of that, the front is at the bottom of the picture, the back is at the top of the picture, is the tongue. You can see some taste buds, look like little circles like the moon. So palate first, and then you see the back of the tongue. Then you see the epiglottis, then you see the vocal cords, and that's where the air is trying to go between those cords, because that's the beginning of the windpipe. Okay?
James, what are you looking for?
Well, right now, I'm just teaching you some anatomy. We're going to show you what we're looking for when we go through our example patients. Okay, so right now, I just want you to understand what you're looking at. And there's no tonsils in this picture, but if there were tonsils, they would be on the left and right side, and you're going to see some in just a minute. So I just want to have this as a reference, so when I show you exam photos, you actually know what you're looking at. That's the purpose. All right, so this first patient I want to talk about is a 53-year-old man, lives in Dallas. Actually, was doing a short job here in Houston, and he was diagnosed with sleep apnea 2 years prior to seeing me, and he also had some complaints of nasal congestion, and he had tried air pressure, and he was using air pressure, and his pressure is very low. He was only requiring 6.5 centimeters, and the range of CPAP machine pressure is between 5 and 20. So he's at 6.5, which is at the lowest end of the lowest setting you can even turn a CPAP on machine, set a CPAP machine to. So, and he was using it about 5.5 hours a night, and he was having only 3 or 4 obstructions per hour. And the reason we know that is because the CPAP machines, they're not sleep tests, but because the air is flowing through the machine knows if you're moving air or you're not. And so therefore it's essentially like having a sleep study every night, because every night while you're on the machine, it can estimate your therapy. I'm sure you look at yours when you use your machine.
Yes.
Anyway, so at the time I met him, I didn't know his sleep apnea severity because he didn't have the test results from 2 years ago. But he did mention that he tried an oral appliance in the past and that he didn't like it because it gave him some jaw discomfort. So he came to see me because he didn't want to use a CPAP machine anymore. And therefore, we retested him with a home sleep test. And the RDI is the number of times per hour that he's having a sleep apnea event. And he was having 55 per hour, which is almost once per minute. And in a 6 or 7 hour night, that means he's having, 400, 350 airway occlusions per night. So
Wow.
one thing I want to point out on this information, I think people think that if they have severe sleep apnea, they're going to need some big machine that blows tons of air. And this gentleman has, a very severe sleep apnea. Severe starts at 30 per hour. He's at 55. I have some patients who have 100 per hour, so I'm not sure what you call them, super severe, but even though he has 55 airway occlusions per hour, he's only requiring very low air pressure to correct that for him, or I should say, to treat it for him while he's wearing that. Okay. And then relating to his nasal obstruction, when I did his exam, I didn't put these exam photos in this presentation, but he did have a significantly deviated septum, and he had big turbinates. So now remember that cartoon picture I showed you of the airway here. So now I'm going to show you his version of this exam. Okay, so this is his airway in my office, wide awake.
Wow.
And there's two pictures side by side. So the left photo is the airway when he is just sitting in the chair. He's relaxed, breathing through his nose, only through his nose. And I think you can appreciate that doesn't look very open, like compared to the cartoon. Okay. And like I tell patients, when I do your exam awake, we're not going to see sleep apnea. You're breathing. You're not breathing when you're awake. So we're not going to see, we're just looking at features of your airway that look suspect. It's probably the best way to put it. So you see that big bulgy thing sticking at the bottom of the photo, that's his uvula and palate and uvula. And then below that, farther down is the tongue, and you can see his epiglottis is actually resting on the back of his throat. If you go back to the cartoon, the epiglottis is very forward in this picture, allowing you to see the vocal cords, which is the white letter V that you see here. But if you go on this picture, you can't even see his vocal cords. Everything is tilted back towards the back of his throat. The back of the throat is the top of the photo, and the front of his airway is the bottom of the photo. Okay, you follow me?
Yes.
Because if you can't follow me, I know people can't see the pictures. Can't follow me, so you're my barometer. Okay, Steve. All right, so then the picture on the right is the same patient at the same time, and all he's doing is pushing his jaw forward for me, okay? Because remember, one of the treatments for sleep apnea is oral appliance therapy. And what oral appliance therapy does is move your jaw forward, or I should say, hold your jaw forward for you passively, okay? And if you look at the left picture and the right picture, which picture looks more open to you, Steve?
Right.
There you go. There's more room on the right. His epiglottis is more forward. Even the side walls are more open. There's even more space between the palate and the back wall. So this is another interesting point about oral appliances is that people think, I believe anyway, that all it does is move your tongue forward or something. But actually, oral appliances improve, for a lot of people, your entire airway. It's improving the space behind the palate. It's improving the space on the sides of the throat. It's improving the position of this patient's epiglottis. So I know from this exam that he does seem to get a very good anatomic benefit from bringing his jaw forward, okay? And when I have him do this, I don't have him stick it out as far, as humanly possible. I have them move their jaw forward enough to be, reasonably comfortable, okay? All right. So after this, he wanted to know, this I have to figure out if I can do this for you. He wanted to know why he had sleep apnea. Okay, so again, the picture in the office is awake, so we're not going to know why he's obstructing. We're not going to understand how this airway is collapsing to give him that test result of 55 obstructions per hour. We just know that this airway isn't staying like this when he's sleeping. And how do we know? Because the sleep test was positive. The sleep test said that every minute this patient's airway is collapsing to the point that he's not getting enough air. So the way that we can best estimate what is going on is to watch him sleep with the camera in the same exam I just did, but asleep, laying down. So that's what this is supposed to be. And I'm going to try to show you this exam. Now, this exam I'm going to show you is his jaw is in the neutral position. And let's see if it'll work. Says the video uses a unique codec that your browser doesn't support. Follow these steps. Oh, torture. So maybe I'm not going to be able to do it for you. That's a bummer. All right, next time we're going to have to figure this out.
With all this, so you've got to do a sleep test so you're accurate.
What's that?
You have to do the sleep test, though. They have to be asleep.
Yeah, well, this video is, again, it's an anatomic test that shows us how his airway is collapsing. And so what it showed was that, and you can kind of see it in this picture of the video, this kind of placeholder picture. This is his airway asleep, but you can see how tiny the space is behind the palate. I mean, look, that's very little room there. And then with his jaw forward, again, just an unfortunate photo. Look how much better this airway is while he's sleeping. You see that?
Wow.
Okay. And I apologize, but next time we do our show, I'm going to make sure that,
do you see the question in the chat line?
Yeah, would a person have to put their jaw where it rests naturally or push it further forward? Okay, so two things. So let me answer both those questions. So the first one is, would a person have to put their jaw where it rests naturally or push it forward further? Okay, so that depends. So if, in other words, I think what this person's asking is, if you were to use a night guard or an oral appliance therapy, do you have to push your jaw forward? Usually, but some people, the problem isn't they need to push your jaw forward. Some people, they just need to keep it from falling back when they sleep, because some people, when they sleep, their whole jaw, falls back. And so just like you get an airway improvement when you bring the jaw forward, you get a worse airway when your jaw falls back. So for some people, it's just stabilizing the jaw. You don't really need to push it forward. But for a lot of people, when I say push it forward, by the way, we're not talking inches. We're talking, 2, 3, 4, 5 millimeters. So this patient chose to try this patient chose to try an oral appliance for treatment. And so what we did is we made, based on the sleep endoscopy, I felt he would do well with an oral appliance. He got an oral appliance. After he becomes acclimated to it, after about 3 weeks of using it, we do the sleep test again while he's wearing it. And we actually do multiple positions. But his RDI, his number of obstructions per hour, went from 55 down to 7 with just a night guard. I mean, that's phenomenal.
That is.
It's not 0, but even with CPAP, he was having 3 to 4 obstructions an hour. So he's only having a few more per hour. And the trade-off is he doesn't have to wear a CPAP machine. So for this guy, he was very happy with that outcome.
You see where Ken asked, do you have to sleep with a camera down your nose?
Yeah, well, you do, but it's only for about 15 minutes, and you're in a chemically induced controlled sleep state that's in a controlled environment. So we're doing this in a exam room or facility. We're not at your house while you're sleeping, sneaking in at night and shoving a camera down your nose.
You brought up tongue. There's a thing called thrust. People who have larger tongues. How does that work with sleep apnea?
Well, it just depends on how it affects your airway. And that's why, let's keep going through these examples so you can see how this works. And say, is there a starting point everyone starts at, or do you get an idea with the first sleep test on where to start? Okay. So sleep test, I think you mean sleep endoscopy, which is the exam I tried to show you. And basically, we're not going to know where to put your jaw for the best efficacy. So that's why we're actually going to do multiple nights of sleep testing, and it's at home at different positions So when we give patients the sleep test kit, they keep it for several nights, and then each night they sleep at a different position because the appliances are self-adjustable. And then you know how you titrate your machine, Steve? How you know your pressure might be 14 and you start at 4, then they went to 5, then they went to 6, and then they keep raising the pressure until you don't have significant amount of sleep apnea events. And that's how we do appliances. We titrate them, but instead of titrating pressure, we're titrating position of the jaw. And I actually had a cool sleep. I used to own a lab, and I had a really neat test we could do that was real time, where we would make a temporary appliance, and that temporary appliance was attached to a tiny motor, and that motor would move your jaw 1/10 of a millimeter at a time as controlled by the technician, and then we could real time see how much your airway improved or your sleep disorder breathing would improve as we moved your airway forward or your jaw forward. All right, let's go to the next. You want to try the next one?
Yes.
Okay. So this patient, real nice guy, he actually had a lot of congestion issues, and he looked tired. I mean, I knew this guy had sleep apnea. He's 40 years old. He's almost 260 pound, 6-foot guy. His BMI was 34. And we did a sleep test on him, and he came back at 61 obstructions per hour. So again, very severe. And then he also had very bad sinus disease, and he had big inferior turbinate. So again, just showing you the cartoon reference anatomy. Bottom is the front, top is the back of the airway, palate, epiglottis, voice box, okay? And then this is his airway awake on the left in the office, sitting upright in a chair. And if you were to tell me, hey, where's his sleep apnea coming from? I don't know if you can tell by looking at that picture.
Both almost look the same.
Yeah, it looks like it's pretty open, right? So that's the problem when you can't operate on somebody based on an office exam, because if you do, you're not going to do them any favors. Just doing surgery to do surgery is not helpful surgery. And then the photo on the right is him moving his jaw forward. And again, if you look at both photos, I think it's pretty obvious that the airway is definitely better in this patient with his jaw forward. Okay. Now, I can't tell you that will solve your problem just by looking at these images. It's not that predictive that way. I can just tell you that you definitely get an improved airway. Just like you couldn't look at the airway on the left and tell me that you have 60 obstructions an hour. You can't look at the airway on the right and say, oh, well, because your left airway with your jaw neutral has 60 obstructions an hour, your airway with your jaw forward, because it's better, is going to have 10 obstructions an hour. You can't predict it. You're going to have to do some trial and error. Just like the example on the first patient, just because you have severe sleep apnea doesn't mean you need a BiPAP machine. You can't predict the therapy just because of the severity. That's what I'm trying to drive home the point.
Dr. Lodo, we're getting a lot of people asking, what if you don't treat it? How dangerous is it?
Well, it depends how bad it is, So it's going to kill you. It's like a cigarette. I mean, it's going to kill you a little bit every day. I mean, that's the best analogy. Every night, depending on how low your oxygen is going, depending on how long your apneas are lasting, depending on how many, you're smoking 1 cigarette a day, you're smoking 2 packs a day, right? Same thing. You're having 2 obstructions, 5 a night, you're having 500 a night. I mean, those aren't the same patient. So, so this patient, sometimes these sleep endoscopies, if I have a patient who needs a surgery in the OR, like a nasal surgery, and we're going to go to the OR, then we'll do these sleep endoscopies in the OR. This is by the way, this space on the left that you see nice and open, this is it on when he fell asleep. No airway.
Wow.
And there's a lot. There's no hole there. The hole's supposed to be right in the center of that picture, is where his hole. That's the center of this picture. Pick one of these photos. The center of that photo is now like this. Okay.
Can't see it.
Dramatic changes can happen when you're asleep. That's why you can go from having an airway that looks kind of benign to having and still have severe sleep apnea. Everything's a clue. There is no like, oh, there it is. Okay. Everything, that's what makes it complicated. That's what makes the treating sleep apnea challenging and rewarding, is because it's not like, oh, I have a mole here and then you just cut it off and you're done.
Right.
That's easy. Anyone can do that. I don't, not to belittle people who remove moles, but it's very straightforward. Like, here it is and now it's gone, But the throat is a muscular tube, and there's pressure changes happening in it. And then there's positional changes and neck changes and jaw changes. And I mean, when you're sleeping, lot of things are happening. And so, and sleep endoscopy is not perfect, but if you can watch these videos, which I promise I'll get them working for you next time, you'll find that it's very fascinating how much is going on in this airway when these people are sleeping. So this person has a circumferential, like it's kind of like a sphincter collapse. His airway collapses in a circle. And that we have to know that, because if your airway collapses in a circle at this level here, then some treatments, like for example, Inspire, which is a neuromodulation treatment, is not indicated. So if we observe this type of, so if you come into my office and you have bad sleep apnea and you can't use a CPAP machine, and you saw an Inspire commercial and you're like, and I had this happen, and doctor, I want Inspire, tell me about it. Well, I can't tell you if you're even a candidate for Inspire, because you have to do the exam of sleep to find out if you're a candidate, because it depends on how the airway is collapsing. But this guy, he chose CPAP as his treatment because he only needed only 8 centimeters of pressure, and he was using it 7.5 hours a night. So he's using it all night long. He feels great. He's satisfied with the treatment, and so he's done. He doesn't want to do any other treatment for his sleep apnea at this point.
You see Harry in the chat, Dr. Ludwig.
Harry. Yeah. Can you have sleep apnea if you don't have any? Well, I don't know. Again, I don't know what that means. Airway obstruction awake or airway obstruction asleep? Sleep apnea is airway obstruction. You don't know you have sleep apnea. That's the problem with the disease. People go years and years and years and years and years with undiagnosed sleep apnea. I mean, I literally have people come in who have had heart attacks, who've seen cardiologists, cardiothoracic surgeons, their internist. I mean, how many providers has this poor guy seen, and yet nobody did a sleep study? And 90% of these heart patients have sleep apnea. I mean, I'm talking clinically significant, not 2 events a night. I mean, they have clinically significant sleep apnea. So it's just another cog in the wheel. It's kind of like having hypertension or high blood pressure, having some diabetes, having some high cholesterol, you're a little overweight. Each one of those diseases checks a box on your risk for a cardiovascular event, right? So what do most people do is they try to mitigate their risk by doing what? Well, they take their pills for their blood pressure and they take their pills for their cholesterol. And I won't put diabetes in the same category, because if you don't treat your diabetes, you really can't feel bad day to day. But the reality is most people that are taking cholesterol and high blood pressure medication do not feel better because they take it. They're not popping their labetalol and like, oh my God, I took labetalol today, I'm going to go bench an extra 30 pounds. I mean, it's not Adderall. Okay. It's not making you feel better. You're taking it out of fear. You're taking those drugs out of fear that if you don't take them, something bad's going to happen to you. Okay. You're going to have a stroke. You're going to blow out your kidney. You're going to have a heart attack. I mean, that's why you take those meds. But when you treat sleep apnea, you honestly, all those reasons are there. The same reasons you treat your blood pressure, the same reason you treat your high cholesterol. Those are all the same reasons to treat obstructive sleep apnea. But because it's not a pill, because it's not something that you can do passively like that, people don't treat it. And it takes work to treat sleep apnea. But on top of treating sleep apnea for the long-term benefit, what you get is short-term benefit, because every day that you use it, you feel better. Like you actually get a day-to-day benefit from CPAP that you feel, but you don't with those medications. So it just cracks. I'll see people come in, they have 4, 5, 6, 7, 8 drugs are popping every day, and they don't even bat an eyelash to do that.
I was on blood pressure medicine.
Yeah, or whatever.
But I was always tired too.
Right.
Always tired.
And the common scenario is this. Well, first, okay, this is how it works. You're tired, you don't feel good, you're in your 40s. You know what your problem is? Low testosterone. That's right. So you go, you get that checked first and get your low T taken care of, and make that doctor rich. And then if you still feel bad, then you get your thyroid checked, because God, it's your thyroid hormone level. That's where's your blood count. It's something like that. And I'm not saying you shouldn't check those things, but it's just interesting that all those things will be checked and nobody checked for a $100 test that you do at home. Nobody checks.
Exactly.
So it blows my mind. It really does. All right. So that's a patient too. I got one more. I do have some, this one you'll like because there actually are some post-op photos I think you'll find interesting. So now this guy didn't even come to see me for sleep apnea. He came to me because, I mean, he was very adamant. He had tonsil issues and nasal drainage and a lump sensation in his throat. And when he lay down, he felt like stuff was draining down his throat. He was just miserable. He had a history of reflux. He had a history of nasal allergies. He said he feels like he's gagging sometimes. He thought maybe it was his uvula doing it. And then, of course, for every patient, I always screen for sleep apnea. He had a lot of sleep apnea-like complaints like restless sleep and snoring and whatnot. And this is not an overweight guy. He's 5'10". He weighs 193. His BMI is only
Oh, that's
28.
not overweight.
Pretty young guy, 36. And then when I examined him, he did have bigger than average tonsils. He also had some nasal anatomy issues. And this is his exam. Again, I just bring up the cartoon so we can all remember what great anatomy looks like. And this is his endoscopy exam on the left. So you can see that a couple things. You can see tonsils. Those big humps
Yes.
on the side are his tonsils. The pictures, the right is on the left side of the picture. So the left side of his photo is his right tonsil. Okay.
Okay.
And vice versa. And then you can see his epiglottis down there. And like some of the other patients, his epiglottis is touching the back of his throat. It's not forward like in the cartoon. It's not, oopsie, sorry about that. It's not forward like in the cartoon picture. It's touching the back of his throat. And then when he brings his jaw forward, look how much better his airway gets. I mean, look how much farther apart those tonsils are.
Wow.
With his jaw forward. So again, you can see more of the inlet to the airway, to the voice box. His tonsils come apart. His palate moves forward, and you can see all the mucus you can actually see the mucus he's complaining about. So you can see all that sticky stuff there.
Yeah.
So that's good that I can show him that he's not crazy. He does have a bunch of mucus in his throat, and we can work on that with some medicines. But he really wanted these tonsils out. That was very important to him. And that played a role in his decision making because it did turn out that he had clinically significant sleep apnea. And then this is just a picture, kind of like you would see if you looked in the mirror and opened your mouth. And you can see that his uvula is in the center and his tonsils come all the way to the uvula. He's got some little white specks in his tonsils. And even through the mouth, his airway doesn't really look very open. It looks pretty crowded. So you could say, yes, I can see some obvious problems with his airway. I mean, he does have these tonsils that are pretty much in the way. Okay. So we did we did some medical management for his mucus and allergies and reflux problems. We did the home sleep test for him, and he came out having about 21 obstructions per hour, 40 while he's on his back. So a lot worse when he's laying on his back, and only 12 per hour when he was not on his back. So like a lot of people who suffer from
Is that normal?
Yeah, when you're on your
back,
gravity is going to make things worse for you. Okay. So he tried CPAP. The machine only he was only requiring 6 centimeters of air pressure to effectively treat his obstructions, but he hated it. He was only using the machine 2.5 hours per night. So this was not going to be a long-term solution. And he's a paramedic. He does have some medical knowledge. So, like I mentioned earlier, when I have patients who have nasal and anatomic problems and we need to correct those surgically, that's a great time to do a sleep endoscopy if the patient has sleep apnea and wants to understand why they have sleep apnea. So he did have a sleep endoscopy, which is supposed to be this slide, and I apologize again, it's not playing for y'all. But it showed that he had collapse in the palatal space and collapse in the area behind the tongue and epiglottis. And when he brought his jaw forward, the epiglottis and tongue got a lot better, but the palate still remained a problem. So he ultimately underwent removal of his tonsils, and then we also did palatal surgery, and this is the before after. So the airway on the left is before I did his surgery, and the airway on the right is after we did palate and tonsil surgery. We did not do anything to his tongue or epiglottis. Okay. I don't do multi-level surgery at the same time. I don't remove tonsils and do tongue surgery and do highlight all at the same setting. We'll do them in stages, but just look how much better his airway is.
Much different. Much
better. Okay. And I'll tell you, it's not fun to recover from this operation, but it's fairly safe and you will heal. It's just not a fun
What does that
recovery.
mean? What does that mean?
It hurts. It hurts for a good,
Oh,
yeah, you're drinking Tylenol with codeine like it's your friend. Like it's,
oh, okay.
yeah, it's like a chronic, intense burning throat for, 7 to 10 days. And I mean, some people it's worse than others. Some people tolerate it better than others, but if it's what you need, it's what you need if you're trying to get off of air pressure. So I don't have follow-up yet on this patient for his. So before we do any other intervention for his sleep apnea, we're going to retest him to see how much better he is. If he has some residual sleep apnea, then he can choose to do an oral appliance, because I know from his sleep endoscopy exam that his epiglottis and tongue gets a lot better with an oral appliance, or he can choose to have surgery on that area to try to surgically improve it. So there's 3 patients. One did oral appliance, had an excellent outcome. One did air pressure, had an excellent outcome. And this patient, hopefully, I think will have an excellent outcome.
Let's see if we can read some of those chats. Gina, you see that one?
We can get rid of this. I think we're done.
If you get tonsil stones,
No, tonsil stones have nothing to do with sleep apnea. Tonsil stones are just concretions that are packed into the tonsils. It's the same debris that you have between your teeth, and hopefully you floss your teeth. And when you floss your teeth, just smell that stuff that you get on the dental floss, and that's the stuff that's packed into your tonsils. But the only way to cure that problem, unfortunately, is tonsillectomy. But there you go. So if you were to have sleep apnea and you want it or need a tonsillectomy, that would be a great person to offer a palatal procedure on at the same time to improve their airway, so that you're also maximally improving their airway for their sleep apnea problem while you're also solving their tonsil stone issue.
how old is too old to remove the tonsils?
It depends why you're removing them. So it's not really an age issue. It's more of a why you're doing it issue.
Wow, we've always heard that you don't want to have your tonsils removed when you get older. And
Right.
that's
It's
not
not. It's
true.
definitely less fun when you're older. You got to have a good reason to take them out. Just like you're not too young to have a surgery. I have people come in. I've seen 2 kids recently that have. I just saw this poor 2-year-old girl that had adenoid tissue 100% obstructing her nose, and the last doctor she saw said she was too young to have it removed. Well, so she's too young to breathe, is what you're saying. She's not too young to not breathe. She's just too young to fix it. It makes no sense. I mean, look, there are doctors who perform in utero surgery. So it just depends what you need and why you need it. That's what determines when to do it.
With your practice, Dr. Ludwig, a lot of times if you go to a dentist, they're going to have the um, appliance. If you go to a sleep apnea doctor, they're going to have a sleep. You do everything. You don't have just one way to treat sleep apnea.
Yeah, right. But the only thing I don't do is the maxillomandibular advancement, which very, very few people want to do. But and I don't
Surgery? Is
do
that
palatal
surgery?
expansion and things like that, but I work with dentists who do. But I think that the important part is when you only offer one treatment, that means you really only have experience with the one treatment. And you may have heard of or went to a lecture about or educated by somebody about the other treatments, but that's not the same thing as day to day in and out doing all the treatments and doing them together to understand how they work together, to understand why people fail certain treatments. People come in often and tell me they can't use CPAP and they want a sleep surgery. And I can tell you a lot of those patients end up with a CPAP machine and are very happy with it. Once we figure out why they couldn't use it and fix the problems of why they couldn't use it, because what they're really telling me without telling me is that they just want to treat their sleep apnea. And they just think that they can't use a CPAP machine. I mean, there are people like that. I'm not saying everyone is like that, but there's definitely a lot of patients who aren't able to use CPAP because they're not coached properly, or they have nasal congestion or other issues that are preventing them from effectively using their CPAP machine, but they don't understand it. Neither is a doctor helping them, so they just fail.
tell you what's really strange is I can't sleep without my CPAP machine.
Yeah, right. But I used to have this. My old partner he was a sleep tech, and he was a Vietnam War vet. He was Gerald, real good guy, smartest tech I've ever met. Really loved doing sleep testing. But he told me that there are patients who get addicted to sleep apnea. I mean, there are people who they lose a lot of weight or something, and they cure their sleep apnea, and they still sleep with their CPAP machine because they're just so used to it, and they just like that feeling of the flow, So to each their own.
Let's get that last question in.
Yeah. If you have sleep apnea, would removing the tonsils swell too much? All right. When you remove a tonsil, you don't have it anymore. So it's not there to swell anymore. It's like taking out your appendix. It's not there, so it can't swell. But in the short term, sure, if you have sleep apnea surgery on your throat, sure, your throat's going to swell in the short term before it heals. So that's why I don't do multi-level sleep surgery, because I don't want to have any risk of losing the airway in the recovery period, because there's so much swelling from doing too much surgery at one time.
Well, the good news is this show has become so important. We extended it to 50 minutes, and we're replaying it again tomorrow at the same time.
The same video as the show. Terrible.
Tell people how they can reach you, Dr. Ludwig.
Certainly our website at sugarlandent.com. We have a contact us link. You're welcome to call. We have real people that answer the phones, 281-556-1102. You can email us directly at MD, that is like as a medical doctor, at sugarlandent.com. And I personally get those emails. So if you have a question or anything, feel free to reach out. I'll answer as soon as I can. And we're open Monday through Friday.
Okay, and I think our producer just left you a message.
Mm-hmm.
If you can. That will do it for us today. And thank you, Dr. Ludwig.
Thank you very much.
This is going to be probably one of our hottest shows, just going by how many people wrote in and how many people called. We'll be back again with you next week with more Ask the Experts. And thank you so much. Hey, stay warm, Dr. Ludwig and Rebel, and we'll see you soon.
Thanks for tuning in today to the Ask the Expert show on W4CY Radio and Talk4 TV. Tune in next week and every week to hear more from our experts on personal injury, insurance, air condition repairs, estate planning, Medicare, and many other topics in the areas of legal, health, financial, and home improvement. See you next week.